As Dr. Arun Oommen mentioned, today is World Cancer Day, and the theme is closing the care gap. So the gap in the care between developing and developed countries, we are trying to shorten that and trying to avoid that. So probably we all know that we are moving away from fitting for all treatment, like treatment to individualized, more precision-based treatment, and many the technologies are helping us to reach that diagnosis, and that precision-based therapy is helping us to give more benefit to the patient and reduce the therapy-related complications also. Like we are trying to reduce the chemotherapy and other toxic therapies and moving to more precision-based therapies. So we thought of discussing one such technology, cutting-edge technology, that's NGS by Dr. Govind G, and followed by how it is applied in the clinical setting, both for the therapy and screening and prevention, that's VRC, and how that can be applied. Such technologies, such diagnosis cannot be disclosed to patients or relatives without a proper genetic counseling that has long-standing impact in the society and family issues also. How that can be managed, that talk will be by Dr. Vijesh. So I'll request Dr. Govind to start the session with the NGS next generation sequence.
Good morning all. Anyway, World Cancer Day wishes to my team, oncology team, as well as the entire hospital. So we'll begin the talk by trying to just figure out what is NGS and what is pros and cons. So NGS by its definition just means next generation sequencing. So what is it? So it's one of the methods to sequence a DNA and analyze it for further prognostic as well as therapeutic impacts. So before going to the next generation, what was the first generation sequencing? So first generation sequencing basically had three platforms. They were called Sanger, Maxim and Gilbert. I think everybody would have heard about Sanger sequencing at least once in their lifetime actually. So we would just go in general about the Sanger sequencing so that we'll be able to understand what is next generation sequencing. So whatever sequencing method, the rule is the Chargaff's rule actually. So Chargaff's rule is, so in my UG days actually, whenever any questions pops in biochemistry, the answer would be Chargaff's rule. So at least you will get half of the marks. So Chargaff's rule is nothing but a statement that in a specific DNA, the quantity of purines should be equal to the quantity of pyrimidines. So that implies that adenine always combines with thymine and guanine always with cytosine. So if you know the one part of the DNA, you can make out the other part of DNA. So that's called base pairing or complementary pairing. So to understand further about sequencing, we should know the basic structure of a DNA. So DNA, what you see is a nucleotide, not a complete nucleotide. In a complete nucleotide, if you can see, this deoxy part would be occupied by another hydroxyl bond actually, OH group. So once you take out one OH group, it's called a deoxynucleotide. So once you take out two OH groups, it's called a dideoxynucleotide. So the principle is that we know one nucleotide combines with another nucleotide by a principle called as phosphodiesterase bond actually. So this two bonds. So it requires an OH group and a ATP. So that the phosphorus get impacted into that and the hydroxyl group will get reduced and form a phosphodiesterase bond. So this is a phosphodiesterase. So what happens if you remove one hydroxyl group? So if you remove one hydroxyl group from one of the nucleotide, that would be a chain termination, meaning that the reaction won't happen further. So Sanger sequencing is nothing but just imagine, keep a broad imagination. So you take a DNA template, a single DNA template, and divide it and put it in 4 different cubes actually. So same DNA template. So each tube has a primer. So primer is nothing but one will attach to one strand of a DNA and helps in growing actually. So and you will have a nucleotide, different nucleotide containing A, T, G and C, and a DNA polymerase which is a reagent or enzymes help in DNA replication. So with addition to that, you will put D-deoxynucleotide of an adenine, thymine, guanine and cytosine in each of the tubes. So even in modern sequencing, you can even radionucleotide the dideoxy group. So what happens is that actually once the primer attaches, you take a tube one, the primer attaches and the chain division start happening actually, and you can see first the A will come attached, T will come attached, and C, G. Now what will happen if a dideoxy A comes and attaches there? So once dideoxy A comes and attaches there, the chain terminates. So you will be able to see that whenever the dideoxy comes and attaches, the chain terminates. So now for the tube one, you can understand that actually A is present in 5th base, 13th base, 10th base, wherever the termination occurs. Now each tube such a thing happens, and then you can plot it on either an X-ray film or a fluorescence film, the different tubes actually, and from that you will be able to sequence what is happening actually. So this is the basics of a Sanger sequencing. Now next gen sequencing, it's almost the same method actually, but the two differences where you need to understand is that it is not a single strand. There will be massive parallel strands which are put in together for the purpose of sequencing, as well as it's a bioinformatic late process. There is no fluorescence, there is no X-ray, everything is a bioinformatics late process. Now, so next gen sequencing, just we'll go through very brief actually. So this was the first, I'm explaining one of the first next generation sequencing modules actually. So you take the DNA, you fragment the DNA, you denature the DNA, now you attach two adapters to two ends of the DNA. Now this is the most important step in next generation sequencing, that is a library preparation where you will make a library of a single DNA. So where you can see that this chip is attached to this DNA fragments with the adapters attached to the chip, and inside the chip they will start replication by help of primer. So the blue one is a primer which is attached, now it has replicated. Now this is one process called bridge amplification, where there is an amplification of the same DNA molecule. So that will again attach to a primer, divide, again bridge amplification, again division, so that you will get multiple fragments of the same DNA. So this much. So from a very small DNA fragment, you are able to make billions of DNA fragments. So that at the end of sequencing, you will have multiple DNA fragments for analysis using bioinformatics, which overlaps with each other, and from where you will be able to take the final DNA product actually, or final sequencing. So these are the two aspects of next gen sequencing. Now we'll go into very basic aspects now. What are the source of DNA for this sequencing? The source of DNA can be anything, any source of DNA from the oral mucosa, blood, tumor tissue, but preferably for the adequacy of the specimen, you always go for either blood or tumor tissue. Now what are the types of DNA sequencing? They are whole genome, where the entire DNA will be sequenced actually, like in your human genomic projects and all. Exome, where you're only the part of a replicating part of the DNA is used, and a focused gene panel where you will use a tumor tissue, something for the lung cancer or a colon cancer, or even a patient with meningitis also you can use CSF as a tumor tissue. And now third part is called, I'll always say that accuracy. So what is the accuracy of an NGS? So NGS accuracy is close to 95%, where 95% of the time you will be able to pick up something actually. Still it will lose 5%. So if you take Sanger sequencing, the accuracy of Sanger sequencing is 73%. So where you can say that actually NGS can pick up 22% more than Sanger sequencing. And if you want to genome including human gene by Sanger sequencing, anybody has any idea how many years it will take by Sanger sequencing to do a genomic study? It will 70 years. So it's literally impossible. So if a boy is born today, by the time you analyze his DNA, I mean the time that his lifespan is over. So there where the NGS came. So NGS can do it in a couple of weeks or 3 weeks, such things actually. Now there's a third generation sequencing. Third gen sequencing is the principle is same. The only difference is that actually there is no amplification in third gen sequencing. It uses single DNA with the latest bioinformatic, and so the error which occurs during amplification is lost. So the accuracy is close to 99%. Now how do you express the results of NGS or Sanger sequencing? So it can be either pathogenic, where we know that okay, there's a library already created from a very huge data of human beings, and whatever your results is definitely pathogenic. Something like you got a BRCA or you get a BCR-ABL where you know that it's exactly pathogenic. And there's a likely pathogenic where there's a small variation in the insertion sites where there is no 100% sure that it's pathogenic, but it's mostly pathogenic. And similarly, there can be likely benign and benign. Now, the major concern is always when you get a variant of uncertain significance or VUS, where today we don't know whether exactly it is pathogenic or benign, but based on today's library, but probably at the end of a decade you may know what exactly it is. So these are the comparison actually. So this is a pretty important slide. So again, we said the Sanger sequencing is a single targeted sequencing where you can identify single target cost effectively, and it can, what exactly it can do is that if your target is pretty big, which consists of 500 to 1000 base pairs, your Sanger sequencing is more than enough or good enough or even better than NGS because it is cheap. It will definitely not miss something of 1000 base pair sequences, as well as it is not that time consuming also when you analyze such a small sequence. The example I would always see something like a BRCA, and also BRCA, if you do an NGS, still you will miss it actually. So NGS is not a great technology to have BRCA. I wouldn't say that Sanger is the best technology, but again, so that's a problem when you have a bulky sequences. Now Sanger sequencing, as I said, it's a low through output sequence, and when NGS is a high throughput where massive parallel sequencing can happen. So again, if you can see that below, it's a fast, and Sanger is good enough, fast and cost effective when you are using a small number of samples and if your base pair is pretty big actually. And NGS can be time consuming, but it is the choice when you have to sequence a very large part. So again, when you take an example actually, so anyway, I mean many of us will be aware about the Nobel Prize which was related to CRISPR actually. So CRISPR is nothing but a gene editing technology where you sequence a gene and you know that this is pathogenic, so you go and edit that gene part so that disease never occurs. So that is one of the methods now they are using in a neurodegenerative disorders where CRISPR can be used actually. So CRISPR, all these methods has come because of NGS. So by NGS you were able to make a library and identify that these are pathogenic. But in a patient, if you know that pathogenic mutation, you can use a CRISPR technology and identify you can use a Sanger sequencing and identify that gene and then edit it off actually. Now, I mean, these are nothing. So these are development in oncology which happened due to NGS. So these are nothing but name of trials actually. They are called basket trials, platform trials, and umbrella trials. So umbrella trial is nothing but all the disease, a single disease. If you take a breast cancer, is put it under single umbrella, and you have identified biomarkers based on NGS, and you are treating the biomarkers in a single tumor. So all disease comes under single umbrella. When you put a basket trial, you say that there are multiple diseases but the same biomarker, and you are treating that multiple diseases with the same biomarker. For example, if it's a HER2 or say there's some biomarker called X in different tumors, actually lung, breast and all, you treat that biomarker X. Now platform trial, this is from the movie Platform, if you can pick it up actually. So platform trial is nothing but there are multiple platforms where you use biomarkers. For us, if you use this lung cancer, there are two biomarkers for lung cancer. You use the first biomarker, and once that first biomarker starts responding, there will be a change of platform and you will go to the second biomarker. Now, this is one of the most important questions we always face. How many patients will be benefited in real world scenario in the era of precision medicine? So, precision medicine, target therapy, or such things are which we always hear actually. So, in reality, only 2% patients benefit by the NGS. So, if you don't really use NGS in the proper way, we may end up nowhere actually. So, what are the other issues in NGS always? Once mentioned. So I'll give you an example actually. So recently AstraZeneca has come with an NGS where with I think it's a 500 gene panel which is used to identify the risk of having a MI later in life. So I'm a person who has done it actually. So my risk was an average risk. My father also tried it. He had a low risk actually, but he got an MI a decade back actually. So so we are yet to have a proper library regarding what exactly is what exactly are the genes which are responsible for each other. So it may take another 2 to 3 decades for us to understand what is the implication of each genome. And if you analyze 500 genome, the problem is that still only 10 will have medicines, or only 10 genes will be able to target it. So at the end of the day, it is not very easy to go in that place. And similarly, there was a article in recently Annals of Oncology where you have analyzed a genome for something else actually, for another patient, for a neurodegenerative disorder, and you find out that actually patient had a high risk of MI, will have high risk of MI later in life actually. So how to tackle that? So they have been doing yearly angio for that patient for the last 6 years and put the patient on ecospin and statin for no reason so far actually. So we don't know what is going to happen to that patient again with the data what is available. Now for the pros and cons, I think we'll go through some examples actually. So this is a 34-year-old male present with altered sensorium. Routine investigation plus CSS study was assay of meningitis. So organs have not grown in culture as well as a PCR-based assay. Not improving on routine antibody. So this is not our case actually. This is a case which has come in NEJ, New England Journal of Medicine. So what next? So what they did was they did a multiplanar sequencing, metagenomic sequencing of meningitis and this is an article which came in NEJ. So they went for a next-gen sequencing, and what they found out was that patient had a hepatitis E virus or hepatitis E encephalitis. So finally you ended up using the highest end technology, find out the organism, but you can be just happy that you found the organism because as everybody knows there is nothing much more you can do actually. The only thing that you have found a diagnosis. So that is one of the cons actually. So you really don't know if you find something in GS, you will be able to do something. Now this is a 38-year-old male. So this is our own case actually. So this is a 38-year-old male admitted and diagnosed with metastatic adenocarcinoma lung. So routine sequencing of actionable targets were negative, and the patient had a poor response to chemotherapy. So this was one of the patients we were able to use the latest next-gen sequencing where even the smallest fragment of tissue could be assessed actually. So this we found out that there was a ROS mutation actually, ROS rearrangement. So you can see that the frequency is very less. It is less than 1%, which means that less than 1% of the cells had a rearrangement. But the magic of oncology or cancers are actually that less than 1% of the tumor is more, or the mutation is more than enough to drive the entire tumor, and naturally we targeted that and he responded. So again this is such a story. So this was another of our case actually. 150-year-old male had a metastatic rectal cancer post multiple lines therapy, but I mean they were immensely rich that they wanted a whole genomic NGS actually. They did a whole genomic NGS. We found a target, and that target we targeted actually, but there was no response. So the problem was that the target we got in the whole genome NGS of a rectal cancer was a target known to cause a malignancy in a lung cancer. So I don't know whether that person will have a lung cancer later in life. So that so with that drug we tried to target this, but it never responded. So 18-year-old female, one case of AML, induction chemotherapy and bone marrow in morphological remission. So MRD to be assessed. So MRD is a minimal residual disease. So that is something which you used to achieve, whether you should go for transplantation or you can end the therapy with simple chemotherapy. So again, the best method we say that actually, so previously it was something called as FISH actually, flow in situ hybridization. So in fluorescence in situ hybridization, the sensitivity to pick up is 10 raised to minus 4. In flow cytometry, it's 10 raised to minus 5, and NGS is 10 raised to minus 6. So naturally, everybody says that okay, you go for NGS and find out so that you can identify the minimal residual tissue. Disease. So, but the problem is that when final data came, when we use NGS, we unnecessarily go and transplant patients actually. That means that you may not require always such precision always in oncology. So even now the flow cytometry is more than enough in such a case actually. Now I would always finish my talk with saying that a success story of molecular oncology, that is always you can say that it's a CML, chronic myeloid leukemia, where everybody is aware actually. So initially when the patients come with splenomegaly, very high counts with lot of basophilia and myeloid markers, we take it as CML. And we would have only one drug or two drugs at that point of hydroxyurea, busulfan and interferon actually. Later on, due to the emergence of good microscopes, we found out that they were a part of missing of long segment of 22, which we started calling it as Philadelphia chromosome. Then later microbiologists again found that it's not just a mere absence of Philadelphia chromosome, there is a rearrangement which we call it as PCR-AVL, which happens in 9 and 22, which was responsible, and we were able to target that with imatinib actually, a drug. So that almost changed the course of the entire disease. So imatinib started. But the problem is that to identify BCR-ABL, we needed to bone marrow and do a FISH in the patient all the time. So every 3 months, which is again a cumbersome process actually. So again, something called as a real-time PCR came where we were able to assess from a blood test what is the percentage of BCR-ABL in this patient all the time actually. So that became again an easier task. Later on, we were able to NGS scheme and we were able to identify different variants of that BCR-ABL, saying that even now there are hundreds of variants, hundreds of different insertions, and we are able to say that okay, which BCR-ABL is more pathogenic or which requires a higher dose, which requires a change of drug, and how to monitor. Even though NGS has helped to result in a scenario where we were able to stop therapy in imatinib in many patients when we found that in the initial transcript was good enough and patient has attained a deep molecular remission early on. So again, this CMN is always one of the success stories in molecular oncology. So now at the end of the talk, I would always ask, is this a cancer treatment in future where the patient will go to the pharmacist and give a prescription, say that, oh, this is my sequence, you can just give me a medication. But I would say that this will never happen, because already William Osters has stated that actually medicine is a science, is an art, not a mere science, because of the huge variability in different patients actually. So with that, I'll end my talk. Thank you.
Thank you, Dr. Govind. If there are no, we'll have the doubts at the end of the session to speed up the process. Next, we'll have a talk on genetic counseling in malignancies. As you know, as more of these genetic tests are available for us, there are other implications about how to interpret these tests for the patients, as well as how the implications for the person as well as for the family. So it requires a proper genetic counseling, and Dr. Vijesh will talk in detail about it.
So I'll be talking about genetic counseling in malignancies. Brief overview. After an introduction, I'll be talking about the components of genetic counseling. Candidate for genetic counseling in malignancies, inherited cancer syndromes, NCCN guidelines, and conclusion. So no prizes for guessing who this is. A slide is here so that I can explain my next slide better. So I'll begin with this, the Angelina Jolie effect. This is an article that was the original article that was published in Breast Cancer Research in 2014 of about how high celebrity profile can have a major impact on provision of cancer-related services. In 2013, Angelina Jolie went public about it, and she underwent bilateral risk-reducing mastectomy and prophylactic salpingo-oophorectomy after she was detected to have the BRCA gene mutation, which was running in her families. The awareness of genetic tests was on the rise. Also, the journal reports ever since that there have been a very exponential growth in interest in genetic tests, especially related to hereditary cancers. Also, followed up by interest in prophylactic surgeries, though it did not convert into prophylactic surgeries significantly. So, although cancer is a genetic disease, most cancers are not hereditary. They are by de novo mutations, and 75 to 85% of them are sporadic. Around 10 to 15 are familial, and 5 to 10 are hereditary. We will be covering this 5 to 10, and also we will be discussing about the familial. So this is a pictorial representation of somatic and germline mutations. As we know, the somatic mutations occur in non-germline tissues. They cannot be inherited, and germline mutations are present in the egg or sperm. They are inherited and cause familial cancer syndromes. This is a pedigree chart. It shows the first, second, and third degree relatives. You can see the proband there. And when we take genetic histories during counseling, we go up to the third degree relatives. So as we know, as you can see, parents, siblings, and children are first degree. The second degree are grandparents, aunts, uncles, nieces, nephews, grandchildren, and half siblings. Third degree would be great grandparents, and so on. Genetic counseling. Although this was defined initially in 1947, the formal definition of counseling was cited and published in the American Journal of Human Genetics in 1974 by F.C. Fraser. I understand this is a bit long, but it covers the entire thing, so I thought this is best to put this definition. I'll just read it out. Genetic counseling is a communication process which deals with the human problems associated with the occurrence or risk of occurrence of a genetic disorder in a family. This process involves an attempt by one or more appropriately trained persons to help the individual or the family to comprehend the medical facts, including the diagnosis, the probable cause of the disorder, and available management, to appreciate the way heredity contributes to the disorder and the risk of recurrence in specified relatives, to understand the options for dealing with the risk of recurrence, to choose the course of action which seems appropriate to them in view of their risk and their family goals, and act in accordance with that decision to make the best possible adjustment to their disorder in an affected family member and to the risk of recurrence of that disorder. So components of genetic counseling, we have diagnostic and clinical aspects, documentation of family history and pedigree information, recognition of inherited patterns, and a risk estimation, result interpretation, communication and empathy, information on available options and future measures and further measures, support in decision making and decisions made, and also surveillance plans. Genetic counseling, we can say, always involves two sections, which is a pre-test counseling and a post-test counseling session. So in the pre-test, we will also be discussing about the various tests which are available. Like Dr. Govind mentioned, NGS is one of the tests which we can offer. The topics covered involved include the genes and how a change and mutation in them results in cancer, the hereditary cancer, types of inheritance, so recommendations for specific tests and testing protocol, results which we might get after genetic testing, which is a positive, negative, or a variant of unknown significance. Predictive testing, it also involves predictive testing for at-risk relatives. If a mutation was found, the management decisions would be made or modified, taking into consideration both the patient's disease status and the mutation detected. For healthy individuals detected to have genetic mutations, surveillance and options for prophylactic surgery where appropriate would be discussed. And understanding of the risk for other first degree relatives would be inculcated, and plans to convey this information to the concerned relatives would be drawn up. So, like I said, there's result interpretation of the results. You have a clear negative, nothing to be done for that, and then you have a variant of uncertain significance. When you have when it is mentioned as likely benign, again it goes into the same thing, nothing to be done in that. But once you get an uncertain significant variant of uncertain significance, which is uncertain, then it is borderline, and for those which are likely pathogenic and pathogenic variants, you follow the medical or surgical management based on the cancer risk. I'll be coming to that later. So the benefits of genetic counseling, they have both pros and cons. They can end an uncertainty about particular genetic mutation being inherited or not. They can clarify cancer risk for an individual, can clarify cancer risk for the relatives, aid in medical or surgical decision making, may relieve anxiety. There are limitations. Negative test results may not always be fully informative. They may be uninformative or falsely reassuring. For example, like in a patient with a familiar clustering of carcinoma, say like the breast carcinoma, with the family having a number of relatives having breast cancer, but we don't have a definite mutation which is a high penetrance gene which is detected in that. So in that case, we will look for high penetrance genes which are going to be absent, and then it might not be truly, it might be a negative but not truly negative, it may not give us much information. So patient may prefer, many people prefer not to know that, especially relatives, to know their genetic status or future cancer risks. The timing need to be optimal. Concerns about genetic discrimination, workplace, insurance related, and all those also exist. So who should consider genetic testing for cancer risk? So this is AIMS genetic counseling criteria. This is what they follow. Sporadic early onset breast cancer less than 45 years, or a triple negative breast cancer which is less than 60 years. Male breast cancer of any age. Early age colon, ovarian, uterine, pancreatic, diffuse gastric or renal cancer that is less than 50 years. Medullary thyroid cancer or adenocortical carcinoma at any age. Multiple primary cancer in one individual, like bilateral breast, ovarian, colon, uterine, renal, thyroid, or multiple primary melanomas. Individuals with multiple or early onset gastrointestinal polyps. Hereditary cancer syndromes are identified. Hereditary or family specific mutation has been identified, or family history of cancer. This is from Ohio Genome Network criteria. It includes personal history, Like we said, adrenocortical cancer, choroid plexus, some of the rarer cancers are also involved in this. Choroid plexus cancer, and I will not be reading all that. And we'll go to the family history also, and 2 or more close relatives of the same side of the family with the breast cancer, uterine or colorectal cancers, combination of these cancers. So inherited cancer syndromes. So this table shows the common inherited cancer syndromes. Like we know, FAP causes colon cancer. Then BRCA1 and 2 will be discussed by Dr. Roja. Lynch syndrome is hereditary non-polyposis colon cancer. This is the most common case of inherited cancer syndrome. They are also known to cause other cancers, if you see in the slide. Leishmania, MEN1 and 2, neuroblastoma, neurofibromatous type 1, retinoblastoma, tuberous sclerosis, von Hippel-Lindau disease, and others. So the NCCN guidelines, NCCN has published guidelines for testing for hereditary cancer syndromes. They provide broadly, it is divided into general guidelines and disease-specific guidelines. These are clinical guidelines to pick up when we see patients in the OP. So general guidelines, general testing criteria, individuals and any blood relative with a non-pathogenic or a likely pathogenic variant in a cancer susceptibility gene. Individuals meeting the criteria below but who tested negative and with previous limited testing. For example, like he said earlier, BRCA was tested in a case of breast cancer with some Sanger sequencing or a microarray test, and later because of strong family history they wanted to go for other high penetrance genes testing also, where you can use NGS technology. If there is a pathogenic or a likely pathogenic variant which is identified in the tumor genome, which has clinical implications, for example, patient presenting with some features suggestive of leishmania, having a TP53 in the mutation in the tumor genome, maybe we can go for genetic germline testing as well. To aid in systemic therapy and surgical decision making, this helps in, for example, if you find with prostate with high with a BRCA deficient prostate cancer patient, it can help us in giving therapies once they progress. It can help us in giving platinum. Also in breast or ovary, you can give PARP inhibitors in BRCA deficient patients. So individuals who meet Leishmania syndrome or Cowden syndrome or Lynch syndrome criteria. So this is for breast, only the high penetrance gene things specifically are tested. So personal history of breast cancer with specific features, less than 50 years, any age, there are treatment indications to aid in systemic decision making. Like I said earlier, pathology also taken into consideration, triple negative breast cancer, multiple primary breast cancers, lobular breast cancers, male breast cancer, and ancestry Ashkenazi Jews. Any age when there is a family history with more than one close relative, or any breast cancer at any age with less than 50 years, male breast cancer, ovarian breast cancers and others. Similar guidelines for ovary also, when there is a personal history of epithelial ovarian cancer and family history. Similar guidelines for pancreatic cancer, when there is an exocrine pancreatic cancer, all individuals diagnosed with exocrine pancreatic cancer. All this, for all these things, general testing criteria is there, and specific disease site-specific testing is also there. First degree relatives also individuals diagnosed with exocrine pancreatic cancer. Then this is for prostate cancer, prostate specifically high grade, high risk and metastatic cancers, they are advised. So this is for colorectal, after taking a detailed family history If we find greater than 10 adenomas, this is to look for the possible polyposis syndromes. We look at FAP, AFAP, MAP, rare genetic causes of multiple adenomatous polyps, CPUE, Peutz-Jeghers, and juvenile polyposis, etc., or greater than 5 or more serrated polyps, more than 2 hematomous polyps. This is criteria for Lynch syndrome. This is Peutz-Jeghers. Cowden syndrome, P10 syndrome, hematoma. There are major and minor criteria. Leaf-Romani syndrome. The genes tested, this is not an exhaustive list. It's basically high penetrance genes. And there are moderate penetrance and low penetrance genes which may also be quite significant from an individual perspective. So some of the genes are ATM, BARD1, they are showing the breast cancer risk, the epithelial cancer risk, and the pancreatic and other cancers. BRCA1 and BRCA2, Dr. Roja will be discussing. BRIP1, CDH1, cyclin D kinase 2A inhibitor, and CHEK2. This is the Lynch panel. NF1, PAL2, P10, RAD51, C and D, STK11, TP53. Conclusion, the genetic services in cancer are evolving as they become more fully integrated into oncology care. They provide opportunities for both patients and relatives to reduce the morbidity and mortality, and for those with inherited cancer risk, they help to stratify targeted therapy. Psychological well-being needs to be assessed. Interpretation of complex tests will remain critical. For example, like I said, if you get a variant of uncertain significance, it can be a likely benign. 90% of them go into being classified as benign later, but 10% will go into being reclassified as likely pathogenic or pathogenic. So the people who are coming in this group, they will need to be kept on surveillance, follow-up, and the recommendations may change. Interpretation, those with those with identifiable gene variants or significant family histories will continue to benefit from genetic counseling practices that help people to understand and adapt to the clinical, psychological, and familial implications of genetic contribution to their cancer. Thank you.
Thank you, Dr. Vijesh. Now we will have a talk on BRCA mutation, its significance and screening of carriers. So breast cancer is now the most common cancer, and as more testing is available, we're getting more of BRCA mutant patients. So how to deal with them? Dr. Roja will talk more in detail about it.
Good morning, everyone. I'll be talking about BRCA mutation and its significance in our clinical practice. According to the GlobalCan data, in India, most common cancer is the breast cancer, and it constitutes about 13.5% of all the cancers. And among females, the breast cancer is about 26.3% of all the cancers. And the hereditary breast cancers, as Dr. Vijesh told, is only about 5 to 10%. And there are certain genes which are causative of these cancers, but the most common among these are BRCA1 and BRCA2. So what are these genes? Actually, when a cell undergoes division, all its organelles duplicate. And when the DNA duplicates, it can undergo numerous errors. And these errors are managed by the repair proteins which are there in the system. And the BRCA proteins are one such repair genes. And it's involved in the double-strand DNA repair and the cell cycle checkpoint regulation. These BRCA proteins arrange different other proteins like RAD50, RAD51 and helps in correcting the mistakes which happen during DNA replication. these proteins are produced by the BRCA genes, which are BRCA1 and 2, breast cancer gene 1 and 2. These are tumor suppressor genes. Who discovered the BRCA gene? It was discovered by Mary Claire King, who was a professor of genome sciences and medicine in the University of Washington. BRCA1 gene was detected in 1994 and 2 in 1995. As Dr. The incidence of BRCA gene in general population is 0.2 to 0.3%. That is, 1 in about 400 people will have this gene. And in the Ashkenazi Jews, the incidence is slightly higher, approximately 2%. So as Dr. Vijesh told, this gene drew so much public interest when this famous American actress Angelina Jolie disclosed that she underwent risk-reducing bilateral mastectomy and bilateral salpingo-oophorectomy on 14th of May 2013. That was because Jolie's mother died of ovarian cancer at the age of 56, and Jolie is the carrier of BRCA1 gene. Jolie did this surgery at the age of 39 years, that is 10 years before her mother was diagnosed with ovarian, 10 years before the age her mother was diagnosed with ovarian cancer, that is 49 years. Jolie told the press that she wanted to see her children grow up and she wanted to meet her grandchildren. So why Jolie would have taken that decision? That is because these BRCA1 mutations are associated with 85% lifetime risk of breast cancer and approximately 10 to 40% chance of ovarian cancers. And the other cancers like pancreatic cancer, the incidence is less, like 10 to 20%, prostate cancer 9.5%, and also male breast cancer 1.2%. BRCA2 genes are also associated with the same cancers but at slightly reduced incidence. Breast cancer 45 to 65%, ovarian cancer approximately 29%, pancreatic cancer almost same 5 to 10%, prostate cancer the incidence is slightly more compared to BRCA1 7 to 26%, and male breast cancer 1.8 to 7%. These genes are located, the BRCA1 gene is located in chromosome 17 and BRCA2 on chromosome 13. The inheritance is autosomal dominant. You can inherit it from the paternal side or from the maternal side. If you have, if your father is affected, the offspring have 50% chance of getting the being carriers, either from the mother also. The offspring have the 50% chance of getting the gene. And whom to screen? In our practice, in the breast cancer patients, we screen in all patients less than 50 years of age. And in patients who have in any age of breast cancers, the patients who have specific histology like triple negative breast cancer or who have multiple primary breast cancers, we screen for them. And any patients with male breast cancer, we should screen for BRCA gene. And in Ashkenazi Jewish ancestry, we will definitely screen. And in who has family history of cancers, like more than or equal to one close blood relative with the breast cancer less than 50 years, ovarian cancer, pancreatic cancer, and prostate cancer, who are metastatic at presentation or who has high risk features, we should screen for this gene. And anybody with the breast cancer who has 3 or more relatives, close blood relatives with breast cancer also, you should screen for BRCA gene. And 2 or more close blood relatives with the breast and prostate cancer also should screen for BRCA gene. And for treatment decisions, we screen for this gene for using PARP inhibitors in metastatic breast cancer and for adjuvant treatment of hormone receptor positive high-risk patients. In ovarian cancer, all patients with a high-grade epithelial ovarian cancer and who are having the family history of ovarian, fallopian tube or peritoneal cancer, we should screen for this gene. And all pancreatic cancers and who has family history of pancreatic cancers, we should screen. And prostate cancer, as I mentioned earlier, metastatic or high risk who are having high risk features, we should screen. And how to screen? That Dr. Govind had mentioned earlier. After doing a proper pre and post-test counseling and post-test counseling, pre-test counseling we should screen, and after the result we should give them adequate post-test counseling also. The test is done by next generation sequencing with a hybrid capture technology which has a sensitivity of 70 to 90%. And more specific is multiplex ligation dependent probe amplification or MLPA. Other method is quantitative multiplex PCR. So once you detect a carrier, what you should do? You have to educate them. In the case of female, you should start from the age of 18 years, and they should be knowing about the breast texture, and any change in consistency should be reported to a clinician. And from the age of 25 years, they should undergo a clinical breast examination every 6 to 12 months. And if there is a family history, 10 years before the youngest cancer in the family, they should start their screening. And according to the guidelines, from 25 to 29 years, they should do annual MRI screening. And from 30 to 75 years, they should do annual mammogram and breast MRI screening with contrast every 6 to 12 months. Every 6 months alternating mammogram and MRI. In age more than 75 years, we have to individualize the screening, and if the patient who is already having breast cancer and with a BRCA mutation and she has not removed the opposite breast, they also should undergo annual mammogram and breast MRI. In case of male carriers, they should start self-breast examination and clinical breast examination from the age of 35 years. It should be done annually. And how to manage if you get a BRCA mutant, what you should do. There are options like risk-reducing mastectomy, but before undergoing something like this, they should be properly counseled regarding the degree of protection, the reconstruction options, the risk and psychosocial aspects, and the quality of life after this. And the mastectomy has offered 90 to 95% decrease in the breast cancer and 80 to 100% decrease in breast cancer mortality. There are other risk-reducing options like tamoxifen and riloxaban, which are having limited use in BRCA variants, but studies have shown that breast cancer risk have come down by 62% in patients who are BRCA2 mutants. Aromatase inhibitors are also used but have limited roles. And what will you do with ovarian cancer risk reduction? We can do risk-reducing salpingo-oophorectomy once the carriers have completed their family, that is by 35 to 40 years. And in BRCA2 variants, they can do the surgery a little later, like 40 to 45 years. OCPs have also been tried, but there is a risk of breast cancer, so limited use. The BRCA mutants should be screened for pancreatic cancer from the age of 50 years. The screening is done with MRA or MRCP, and if they have one or more first or second degree relatives with the pancreatic cancer in the same side of the family, they should be screened. Otherwise, it's not recommended. Prostate cancer should be screened from the age of 40 years, and is recommended mainly for BRCA2 carriers, and BRCA1 carrier also may be considered for screening. It's done by PSA and digital rectal examination. So Dr. Vijesh had told in detail about the Jolie effect. After the Jolie's public disclosure about her surgery, actually there was almost 300% increase in the contralateral risk-reducing mastectomy, and 250 times increase in the screening for BRCA mutation based on the family history in the UK, and the risk-reducing mastectomy also gone up with the according to this article published in the British Cancer Research. In India also, the genetic test and screening based on family history significantly went up, and according to this article published in JCO Global Oncology, the prevalence of BRCA1 and BRCA2 mutation in India is 21.3%, but it is selective population, so bias can be there, and the BRCA1 was detected in 15.5% and BRCA2 5.9%. This is the data according to the different studies which have been published from India. The BRCA1 and 2 prevalence ranges from 18 to 25%. This is our data of the year 2022. We have tested 84 patients who has the indication to be tested for BRCA gene, and the positivity was 19 among the 84 tested, and the variant of unknown significance we detected 7 in that. The breast cancer patients tested by 57, and out of them 12 were positive and 5 we got variant of unknown significance. And ovary 26 was tested and 7 were positive. Pancreas 1 was tested and the variant of unknown, we got it as variant of unknown significance. And after almost a decade after her mastectomy and oophorectomy, Jolie's children have all grown up, 3 adopted and 3 biological, and she is successfully leading her filmmaking and doing her humanitarian works. Thank you.
Thank you, Dr. Roja. Just a correction, because many people would have thought that our incidence of BRCA mutation is very high, but that is a selective registry from the hospital where the risk of getting a BRCA mutation is very high. It's not a population based. The initial ones which were mentioned were the population based data. Our population based data will be much more, maybe to the same as the general population data from outside countries, or maybe lesser. The data which she mentioned was from the selective patient where we suspect them to be positive. Any questions?
When you ended the slide saying that somebody go into the medical shop, that's a slide that we also saw for many of the metabolic diseases. But just wanted to ask you, with this, there's a lot of CRISPR-Cas gene editing that has come into the thing, and NGS has been combined with many of the CRISPR-Cas gene editing. So, are there any trials running so that we can find the gene, go to the pharmacy, and get that done? On a lighter note, the second is also from the endocrine point of view or metabolic point of view, we have a lot of developmental origin of adult diseases. So a lot of these mutations, even though we look into the routine genetics, we don't find, but it is in the epigenome.
Yeah, true.
So how well will NGS work there?
So regarding the, I'll take the first question once actually. So first question, as you said, the CRISPR editing technology is going pretty heavily in oncology also. But there was multiple articles and there was comment that but we just know a very few % of pathology genes as of now actually. So if we go up and do a CRISPR, whatever it's on phase 1 actually, and as any medicine takes 13 years to come into the picture, I think CRISPR will also take at least 13-15 years to come into the picture actually. By the time I think we'll have a better understanding of all the genomes actually, at least the intron sequencing. Now that's the first part. And as I said, I told my father's story who did a NGS for cardiac disease and it came out as a low risk actually, and finally he went away. So I don't think it's a single factor which has an impact in any of these diseases. The second point is the major problem in oncology is also the epigenetic problem actually. So the epigenetic silencing is again one major factor. So that's why we always go for focus disease-based gene panels, where if you go for just the intron panel actually or the exome panel, we may lose it actually. We may lose the epigenetic part, especially in diseases like leukemia. So if we go for a focus panels which have always epigenetic silencing has been described, we have such panels where we use actually like lung, AMLs and all, where we can use that actually. So it's available as a focus panel, but the problem is that for many diseases we don't know what is happening around. So that issue is there.
Any more comments or clarifications?
Roja mentioned such mutilating surgery for prevention of breast cancer. Is there any therapy available where they can alter the gene and prevent?
So that is a CRISPR one, madam, actually. That's a CRISPR technology where you can edit the gene, but as we said, that is in the phase 1 actually. Probably at the end of this decade, we may be able to be better understanding. The problem is that a single gene may be responsible for good and bad things actually. So that is why the CRISPR editing has a problem. So I will just give an example. So if there's a gene which causes a mutation which causes a neurodegenerative disorder, and the same gene if unmutated can help in your intelligence actually, and you get a variable of functional significance and you take out that gene actually, probably that would have never caused a disease and would affect probably a decade later only we'll know that what was the use of that gene actually once we take it out. So that is a problem. So but again, as Dr. said, surgery is breast actually, surgery is an option, not a compulsion actually. So in breast we can be the screen with the same efficacy without a surgery also. With an annual 6-monthly alternating mammogram and MRI of the breast, and with a better breast awareness and a clinical encounter, breast is easily screenable. So surgery is not, that's a part of the Angelina Jolie effect actually. Surgery is not 100% required in breast management. The problem with ovary is that ovary as the like the abdomen and the pelvis are Pandora's box actually, we don't have any symptoms of ovary. We get the symptoms pretty late on actually. So that's why we go for restricting salpingoophorectomy is a must in those patients.
Okay, thank you.
It's more of a clinical question. Suppose a patient is diagnosed to have lung cancer, and when we take history, many of their relatives, maybe even 2 or 3, they have cancers in other organs like colon or ovary. So in such case, what should be the next step? Could it be labeled as sporadic, or should we ask them for genetic sequencing or a periodic screening? So what's the usual protocol for such? Like maybe 2 or 3 relatives in a family have a cancers, but affecting multiple organs.
Yeah, they would require, definitely they would require genetic counseling and testing.
Is there any correlation between the paraneoplastic syndromes and the genetic testing in any of the cancers? That's the first question. Second is, recently we had a patient who had a very high PSA, and the prostatic biopsy was negative. So is there any correlation of a high PSA with any other cancers?
As far as I know, I think high PSA is with prostate only, and non-specific elevations also can come because of severe prostatitis and things like that. High PSA.
This high PSA was in the tune of around 156. And so we had a recent paper, the paper was in 2007 I think, where they have described non-follicular lymphoma with very high PSA producing. The patient is still admitted over here.
Okay, so in general, sir, we say that any tumor markers or any biomarkers should be sensitive, specific, proportional tumor load as well as cheap actually. So as far as prostate is concerned, the first part, sensitivity is pretty high in the sense that it is always an organ of prostate. It usually comes from the prostate actually. So unlike other cancer, it will cause it, but it's not in the cancer. So a prostatitis can have the PSA on the tunes of 500 to 1000 actually. So it's possible, yeah. But again, the next problem is that actually one of the hallmark of cancer cells is differentiation. So the more differentiated any cell is actually, the cell will behave to the primary organ and give a tumor marker. So any cancer cell which is undifferentiated can give rise to any elevation of tumor markers. So that's why tumor markers is not conclusive in any, except for beta HCG, which is only from the syncytial trophoblast, and in a specific scenario can be used as conclusive as a perfect tumor marker. None of the tumors has such perfect structure. So we need to identify the malignancy, do a biopsy, and then only the tumor markers will become of the importance. So this is one of the issues where we always have the tumor markers.
Can this whole genome sequencing detect other hidden mutations? Because we do for a cancer, but can it detect other like congenital myopathies or?
Yes sir, definitely it can. Definitely it can, unless we have a library which has a known pathogenic actually. So if we know that there's a gene sequence ABC causes a myopathy, then when you do a repeat sequencing, and if one of us get the same genome, we can say that okay, this mutation can lead to myopathy. But the problem is that if we don't.
Yeah, so in that report, do they give the clinical significance also?
Yes, they will give, sir, actually. But whole genome sequencing is expensive, time consuming, and not practical actually. So that's why we always go for focused panel NGS. But if you have all the resources available, yes, we can do actually.
So if there is no more questions, before concluding, we just heard about our Managing Director, K Abdulla, inaugurating an advanced lab analyzer in our biochemistry department. So we have the company officials will be talking in very brief about the lab analyzer for our understanding. Okay, what's your name? Sharat will talk about our recently acquired advanced lab analyzer.
So I think we'll step down from the stage actually. Thank you. Thank you for listening.
Thank you so much. Thank you.